Hi, we're a group covering the knee menisci structure and function. I'm Connor.
I'm Frank.
I'm Amy.
I'm Anna.
Ready?
So each knee has two menisci, a medial and a lateral one. They're fibrocartilaginous discs, and they attach at the tibial condyle. And when you put them to, when you look at the whole tibia from the top, they have sort of a stadium shape.
Okay. So as you can see, the lateral meniscus and the medial meniscus make that stadium shape that we were talking about. So the medial meniscus is the larger of the two. It's more of a C shape rather than the lateral meniscus is a little squatter. And it covers 50% of the medial tibial plateau right there. And it has both anterior and posterior horns. And the anterior and posterior horns are separate from each other and from the anterior cruciate ligament, or the ACL. The posterior horn of the medial meniscus is the main secondary stabilizer for anterior translation, and the semimembranosus will attach here as well. Moving on to the lateral meniscus, it's the smaller of the two, like we said. It's more mobile than the larger medial meniscus, so therefore it's more prone to injury over chronic time. And it's more of an oval shape instead of that C shape that we were talking about. And it covers 70% of the lateral tibial plateau. And the anterior and posterior horns of the lateral meniscus are closer to each other, and they're very near the insertion of the ACL.
Right, so there's two main ligaments that attach to the menisci. The first one is the transverse intermeniscal ligament, and that one connects the anterior horns of the lateral and the medial menisci, so it kind of stabilizes the two and holds them together. The coronary ligaments connect the inferior edges of the meniscus to the periphery of the tibial plateaus, so those ones kind of stabilize the menisci again and hold them into the tibia.
So the function of the menisci is to provide shock absorption. It provides load sharing across the whole surface of the tibia to basically reduce the contact stress. So you can see if we don't have a meniscus like we do here, it would basically just be bone on bone, and we all know that would be very uncomfortable. It also deepens the knee joint or the tibiofemoral joint. We also allow the meniscus to provide stability, and it helps protect the knee joint, and it allows the bones again to slide freely over each other without any pain or other impacts. However, it does limit some of our motion. So the stadium shape of the meniscus prevents extreme extension and extreme flexion, like you could imagine. So that stadium shape is gonna not allow us to do this, and it's also would not allow us to go like this. When we are doing full range of motion though, that is allowed, the medial meniscus takes on about 50% of the load when we're in full extension, and the lateral would take 70% of that load. Then when we're at 90 degrees of flexion, both of them are gonna have an equal 85% of pressure for that load. And then anything past our 90 degrees of flexion, that posterior horn is gonna take most of that load.
All right. Now we have the blood supply to the menisci of the knee. The quality of the blood supply to the knee determines its healing potential. We also saw this in the scaphoid bone. And what this means is that the more blood supply there is to this bone, or meniscus in this case, the easier and faster that it will heal. So the peripheral, or the outside 1/3 of the menisci, is vascular, and so this will heal very well if torn. So if it's not that major of a tear, or it's not too traumatic, then this can heal very well. The inner and middle 1/3 of the menisci are avascular though, and so they are not easily as healed. Though the inner portion is, because it is surrounded by synovial fluid, this is also nourished by that synovial fluid. The blood supply to these menisci originates from the medial and lateral genicular arteries, which, as we know from the class PowerPoint, this stems from the popliteal artery. When there is a tear of the meniscus, this may cause bleeding inside of the knee joint, and this will then lead to swelling, but we'll talk about injuries in the next slide. So injuries and treatment to the menisci. Well, first, as we talked about in lecture, the medial and lateral menisci are injured in two different ways, or commonly injured in two different ways. The medial menisci is usually from an acute injury, and overall it is more injured than the lateral menisci. So something that could be would be if you have a stable foot, like in this example, and you have your femur twisting, this can cause a tear in the menisci, which will cause bleeding, as we talked before. And because, I believe it was mentioned before, the menisci is also the insertion point of the semimembranosus tendon, and so this can also cause injury to the when there's injury to the semimembranosus, this can cause injury to the menisci, and which will in turn cause damage to the joint capsule itself. Talked about before, there's a difference in the medial and lateral injuries. The lateral injuries to the meniscus are usually from chronic overuse, so that's you're extending a lot in sports athletes, you could see this. There's two different ways that you can repair the meniscus. You could either completely remove it, which is a meniscectomy, or you can just repair it. It's preferred by most surgeons to actually just try to repair the meniscus if possible instead of removing it, as removing it will cause long-term damage later down the road.
All right, so as you can see, the medial meniscus here is a lot larger and it's more of a C shape, and the lateral meniscus has more of a curve, making it an oval, and it's slightly smaller. And so the way this would work is when the femur attaches here, those would help deepen the articulation between the femur. They also lie right underneath it, so they can help with the shock absorption, and they can also help limit a little bit of movement.